Hello and welcome to our webinar, Co-Creating Pregnancy Plans with Disabled People, the Accessible Pregnancy Action Plan Model. Today, this webinar is presented by our partner, Dr. Kara Ayers, who I will introduce in just a moment. We are so happy to have you here today. My name is Nicole Lamerson, and I'm a research associate at the Lurie Institute, working on our portfolio of disability and pregnancy projects related to disabled people. I am also a physically disabled mom. As a brief visual description, I am a Caucasian woman with brown hair and blue eyes, wearing a blue cable knit sweater. Please use the chat to let us know if you have any accessibility issues or concerns. For example, if you cannot see the interpreters. We will be sending links through the chat throughout the webinar, and we will also send out those links via email to you along with the webinar recording. We hope to have enough time for you to ask questions at the end. To ask or submit a question, click on the button with the two speech bubbles that says Q&A on your screen. Please feel free to submit questions at any time. This webinar is being recorded, and we will email all attendees the recording once it is live, and we will post it for you on our website and on our YouTube channel. For those of you who have opted in for the ICEA contact hour, we will send your certificate via email by mid-March. Only attendees who view the webinar live will be eligible for the contact hour. If you did not register for the ICEA contact hour on the webinar registration, but if you'd still like to receive that contact hour, please complete the Google form in the chat. You can also reach out to us via email if you have any questions about that. Our contact information will be listed in the chat. I'd like to, can we get the next slide, please? This is just a visual of our closed captioning and interpretation slide. Next slide, please. The contents of this presentation were developed under a grant from the National Institute on Disability, Independent Living, and Rehabilitation Research. NIDLR is a center within the Department of Health and Human Services, and the content of this presentation is solely the responsibility of the authors and speakers and does not necessarily represent the official views of NIDLR or HHS. I'd like to take a moment and introduce Dr. Kara Ayers, our brilliant partner and lead creator of the Accessible Pregnancy Action Plan. Dr. Kara Ayers is an associate professor at Cincinnati Children's Hospital Medical Center. She's co-founder of the Disabled Parenting Project and a co-investigator for the National Center for Disability and Pregnancy Research and the National Research Center for Parents with Disabilities. Kara is also a mom to 3, adopted and not adopted. Okay, I'm going to turn it over to Kara.
Thank you so much, Nicole, and thank you to you all for joining me for this next close to an hour where we will be talking about the Accessible Pregnancy Action Plan. I'm really excited that this work is kind of out in the world, and it should be a great discussion. All right, so in the next little bit, we're going to discuss some of the discrimination and health disparities faced by disabled birthing people in the U.S., which really motivated the need for an intervention like the APAP or the Accessible Pregnancy Action Plan. We're going to talk about the plan itself, of course, and how to use it. And in doing so, we're going to talk about power sharing facilitation strategies, strategies that I hope that you would be able to take after this webinar to either facilitate a plan or train someone else to facilitate a plan. And so really, we're going to talk about how we center disabled pregnant people in the process and how we help in navigating what can be really complicated clinical systems that people have to figure their way through during pregnancy and beyond. So in getting started, what is an accessible pregnancy action plan? It might be evident in the name that I was pretty resistant to naming this a birth plan, just saying it straight out. So, as we started developing this plan, I think I dropped off right where I was discussing sort of my bias about birth plans, in that I had previously heard kind of maybe silly things like you had too, that birth plans were things like, I want green M&Ms after birth, and I want, and those were sort of especially that preconceived notion that I had about birth plans was especially frustrating to me as a disabled mom that had two pregnancies, when I felt like I had very few choices throughout much of my pregnancy experiences. And I had great care. I had good relationships with my doctors, but I, really had limited choices. I couldn't deliver at the hospital that was closest to my house, because I had my births under anesthesia. My husband couldn't be in the room. So I certainly wasn't down to the detail of getting to pick, what snacks I wanted. I was really worried about some what felt like more basic critical needs, and I wanted everyone in the room with me to know what I needed to stay safe as well. My disability means that my bones break easier than most. So part of my plan was making sure that everybody who had anything to do with my care was aware of that and wouldn't put me or my babies at risk. So our plan is divided into three periods. So the pregnancy period, labor and delivery, and then those first few days after the birth, which usually takes place in the hospital. And this plan or this time period of the plan is especially critical for parents with disabilities, not only because of healthcare needs, as you're recovering from a major life event, you've just given birth, but also because of, unfortunately, the discrimination that many parents with disabilities face in the hospital, where they may have their parenting abilities questioned. And that's backed up by research and, unfortunately, a large number of personal experiences that people have had. So, our plan is created through engagement between a peer facilitator and the person with a disability who's pregnant. And we use a couple of theories. I'm trained as a psychologist, so I base a lot of what I do around understanding what framework or theory is going to guide what we're doing. And so this is based around a empowerment theory, and then also the best practices of patient-centered communication. And we'll talk more about those. Next slide. All right, so as we got started, we dug into the literature because we wanted to understand what sorts of gaps could a plan like this try to help bridge. And because we can't solve everything, we at least wanted to be aware of many of the challenges that disabled pregnant people face. So, time and time again, we saw that barriers in communicating with their providers were mentioned as a significant challenge for pregnant people with disabilities. And we saw that across prenatal care, through pregnancy, when they were giving birth, and then also, again, those first few days after birth. We also saw the benefits of patient centered communication. We saw that that could sometimes improve outcomes and related in positive outcomes, which is always good. And we pulled in some research related to peer support models, where we realized that people with disabilities really have incredible wisdom and support to offer others. And so we wanted to figure out a way to build that into the plan in some way. And so we did that through the direct facilitation. And then finally, we heard, and many of us, as I've shared, have experienced from our own experiences being pregnant and disabled, that there's often this missing piece of autonomy and empowerment. So I remember one of the quotes that still stands out to me related to this work is, I was working with a disabled woman late in her pregnancy. She had just a few weeks before she was to give birth. And I asked her about, what was the plan? What method of birth was she planning? And she kind of looked at me with confusion, as if, was I asking the right person? And so when she answered, she told me, well, the doctors told me that I'll be doing this and this. And she was really quite disconnected from, I couldn't tell in her answer, was that what she wanted? Had she been a part of that plan? It really seemed as though she'd been instructed what she and her body would do on that day. And it struck me as just really a disempowering experience for her. And as I shared, there were parts of my plan that, due to medical needs, couldn't go exactly as maybe, I dreamed or wished. But to have someone validate my preferences and needs and wishes and hopes
would have meant the world. And also exploring, okay, well, what have we looked into to see if those things would be possible? So, and in my experience, we did look thoroughly into the possibility. Could I have an epidural where my husband could be present and I could be awake? And due to a series of spinal surgeries I've had, that wasn't medically possible, but we really explored it. And by the end of the process, I felt validated that we'd done everything we could to look into that possibility for me. Next slide. So this plan is different from other birth plans. There are no green M&Ms in most of them. Of course, you could add that if that's your preference, but usually we end up talking about, yes, some disability related needs, but also what's really important to people and what they value. And so the APAP is co-created across usually 4 to 6 sessions, usually on Zoom. It could definitely be done live. That would be wonderful. We, for piloting purposes, wanted to reach people from across the country and schedule it times that were convenient for people. So we piloted with people over Zoom. And again, the plan itself in our facilitation recognizes that pregnant people with disabilities are not always treated fairly, and so we directly discuss stigma in its creation. Next slide. So we've mentioned peer facilitation, but I think I can't stress that enough, and that it's really non-negotiable if you're truly implementing this intervention. The intervention itself, if you printed out the columns that we'll see, and we'll see that kind of intentionally at the end, because that's sort of just a way to visually organize the information. But the magic of the intervention and what we think makes it so meaningful is really that opportunity to think through the process with someone else. And we also think that it's highly unfair to look at someone who's never given birth before and say, what accommodations do you need for your pregnancy or for your birth or for the few days after the hospital stay? Because many times people look back and say, well, I don't know. I've never done this before. I don't know what's available. So we really start the experience with guiding people through that and doing it together. They're not just filling this out by themselves. That wouldn't be a true implementation. We also have an opportunity to talk about shared living experiences that really help build trust. And we can talk through things like stigma related to what it's like to be pregnant with a disability. And we hear many times that the person participating doesn't have anybody else in their life who has that shared experience. So it's kind of a one of a kind opportunity. Also, as a facilitator, your role extends beyond just developing the plan. So ideally, you would take opportunities to do some research between sessions as you get to know this individual. Maybe they have disability specific concerns that you may be able to poke around and find some resources with patient advocacy groups or in their community. So kind of the sky's the limit. I would say the floor is, simply assisting someone to fill in the plan. We really want to ideally go beyond that and build this trusting facilitation relationship that's going to take place over these sessions. And and both individuals are cross sharing during this experience as well. Next slide. One of the core principles of the Accessible Pregnancy Action Plan is that it really requires individualizing, which is why it was somewhat challenging as we started to figure out, okay, how are we going to write a guide for someone to do this? Because it felt like there were so many areas that we could have just put, well, it depends. We didn't do that, thankfully. That wouldn't be very helpful. Instead, we pointed out things like session pacing. So for some people, they may want to combine sessions, and there's a few different reasons to do this. They may have relatively fewer accommodation needs or preferences that they want to build into their plan. Other reasons that we've combined sessions is that people may only find out about the opportunity to develop their plan later in their pregnancy. So they may, not necessarily need to build out the pregnancy part as much. If they're, a week or two from giving birth, then we want to focus on that section, and we may need to combine some of the earlier sessions. And so we've outlined here, as you look in your guide, that sessions 1 and 2 can combine, and sessions 3 and 4 can combine. But there is some work to do in between there. So that allows us to pause and do some homework and some implementation, which I'll talk about in a bit. Also, it's important for flexibility in the format and delivery. We talked about Zoom or in person, but some people have wanted printed plans. Others have preferred digital documents. I know I've been asked to send plans to people's phones so that they could quickly pull it up in their appointment. The sky's the limit. I love how creative many times our disability community is. So the format, it could vary person by person. I can envision even that you could record pieces of it, audio, to remind you of what you meant by certain bullet points in the plan, because we do try to capture the whole plan on one page, which after you've worked together for, several sessions, that can be a challenge, but you want to try to not have it be a massive written document. Um, Also, we know that people need different levels of detail in their accommodation planning. So that's, yet another way that we individualize this, and just remembering that each disability is unique, but even beyond that, each individual with each individual disability is unique. So even if I've worked with someone who has had a particular disability before, I'm not assuming that that next person needs or wants the same accommodations. That doesn't mean they can't benefit from me brainstorming with them and suggesting, have you thought about this or have you thought about that? But certainly not kind of copying and pasting. And another approach that we took in the development with this is, I mentioned how unfair I think it is to just ask that blank question of what accommodations do you need without any background. We did a lot of work digging up, what accommodations have been helpful to people with a range of disabilities. And we realized that sometimes people benefited from what may have been brought up in the research in a totally different category. So, for example, we found that sometimes autistic mothers, may have benefited from some of the accommodations that came up, shared in articles about blind mothers, because blind mothers wanted to be kind of given a heads up before someone was going to touch them. And we realized that as we worked with many other participants who expressed a need for that as well, they didn't have to be blind. So we didn't categorize people kind of into like, this is your accommodation list if you're blind or if you're autistic. We realized that we could borrow from each other. And we didn't approach it with, unfortunately, the gatekeeping that you see in some sectors where, I'm not sure why people aren't willing to just say, here are some accommodations that we've offered or that we could offer. I think there's some fear in that, oh, well, what if people pick them all or pick too many, and we don't agree with that approach. So we were more open in sharing what has worked for other people. Next slide. So as you're building momentum in the APAP, and we're dug in now, between sessions 2 and 3 is really a great opportunity to pause so that people can talk to at least one of their support team members about the plan itself. So this usually, ideally, is a member of the healthcare team, but there have been times that I've worked with pregnant people who have said, I'm not really, my first step is not my healthcare team. It's actually my support team that'll be with me. It might be my partner, it might be my family member. And so it's really up to the individual who they're going to kind of get on board first. And then ideally, we want to build on that. I think in best case scenarios, we have both support teams on board, well informed about the plan, as well as the healthcare team, and then everybody kind of knows what the needs and the wants are for the process. And this really allows us to move the plan from a theory of what we want, what we dream of, to practical, let's put this into practice. Also, it usually gives us some time to figure out, if we do it between the second and third session, it gives us some time to figure out, say the healthcare team says, okay, we don't have that in place, but we can figure out if we can, or we can, unfortunately, we're all familiar with we need to get back to you on that. So that gives us some time to hopefully have some more success. And then at each subsequent session, we continue to talk about the progress in sharing the plan. We can problem solve barriers together. We can document what worked and what didn't, because that will not only help the individual you're helping with at that moment, but future participants as well. And just encouraging that ongoing communication to help refine the plan. Sometimes people change their minds too, which is totally fine. We've shifted gears sometimes about a number of different things that people have or haven't wanted in their plan. And I say that intentionally, in that plans are also what you do want and also what you don't want. So we include both. Next slide. So after you've wrapped up your slide, there's a bit of a excited nervousness, I think, in waiting in terms of, okay, when does the plan go into effect? Meaning, in the case of the birth and labor part. And as a facilitator, I don't usually know exactly when that is. I've worked with people in the pilot across the country, but what I tell them is that I would love to follow up with you about 4 to 6 weeks after your birth. That gives people a time to adjust, a time to recover. Too early contacting them to ask them about the plan and how it went can feel intrusive to people as they're just beginning, life with this new life. And if people want it sooner, I think that's a way that you could individualize. But usually people are great with that 4 to 6 week kind of time period. And then you can have a chance to find out what worked, what didn't. And you can also talk about some maybe ongoing barriers. And the great thing is you can bridge, hopefully, to resources now for parenting. And lastly, just closing that loop with appreciation that they shared this, incredible part of their lives with you, and validating their experiences is the ideal way that we want to wrap up the intervention itself. Next slide. All right, so just remembering our dual purpose, we want the plan to both be practical, things that we can do, things that we can put to use, but also empowering, and the process hopefully facilitates that as well. We're going to be countering stigma together and discrimination, breaking down those myths that sometimes even as people with disabilities we take in and believe about ourselves. We're going to be building confidence and agency to speak up. This is your birth and your delivery and your child, and you have a right to ask for things that you want. And throughout that process, developing those communication skills and creating a sense of control. Next slide. So this slide has a summary of our topics that we cover in the sessions. And again, this was how we laid it out via Zoom. So the first section titled Introduction and What Matters Most. And gosh, that phrase comes back time and time again because it's really sort of our grounding phrase in the intervention that helps us remember what matters most to the individual is what we want to center our discussions and in our plan around. And it's really interesting because sometimes what matters most is not exactly what we can implement as the final outcome, but we want to validate and acknowledge that we've done all that we can to do our best to see if the person can bring to life what matters most to them. And so to give you some examples about that, I've had people bring up things like what matters most to me is that I have a chance to have skin to skin contact with my baby as soon as possible after birth. Um, Another what matters most that I've had is what matters most is that I can trust that those around me are going to be communicating with me throughout the entire process so I know what's happening. That's what matters most to me. So what matters most can vary a lot. And what I really emphasize is it matters to the individual. It's not what you think should matter most, what you think you should say, what your doctor would say, what your partner would say. It's what the individual says. So next up, we have the sessions broken into planning pregnancy accommodations, planning labor and birth accommodations, and then planning accommodations for that hospital stay. And then as we're wrapping up, by this time we've built a relationship with the individual and we have some trust and rapport. And so it's a good time too to talk about coping with stigma and refocusing on what matters most. And then last, we have that concluding session, which is a check back after the birth has taken place. All right, so I'm going to give you a peek into what the intervention looks like. We have a slide deck that, as a facilitator, you would walk through. And so this is one of our first slides where the individual is invited to share their pregnancy story. And this looks all kinds of different ways for people. Sometimes people have long, detailed ones. Sometimes they have short ones. But you have a chance to chat about some, intimate personal details. And so the facilitator is also encouraged to share back their pregnancy story in a brief way as well. Of course, we're centering the participant should be doing most of the talking, but this has an opportunity for the facilitator too to share, here were some reactions that people in my life had to my pregnancy. It wasn't what I expected, or it was what I expected, or, so the pregnancy story sharing is one of the ways that we start the process, and we find that builds some rapport. Next slide. This brings us to, and in that very first session, we addressed this question, what matters most, WMM. And it really is more than just a question. It's a research-based approach that allows a person to think about and prioritize their values and what they find most important. And we encourage them to steer away from kind of self-doubt or self-questioning in terms of, again, like what they think they should say. And it allows people to reflect on their perspective and what matters most. Next slide. So we have that built in a visual way, and we'll see that repeated throughout the facilitation of the measure. And so I just wanted to point out kind of why you see that a few times is because it's so important that we revisit it. Now, for some people, things haven't changed, and their what matters most may remain the same. In the piloting of this intervention, we were in the earlier years of the COVID pandemic. And so for some people, their what matters most really included prevention strategies not to become ill with COVID during different steps of their process. And for some of them, that changed as they went through. For some of them, it definitely did not. It was a central part of, all three parts: pregnancy, labor and birth, and the few days after. But there are lots of different reasons why people's what matters most might change, but sometimes it stays the same too. Next slide. So this is, again, an example of a slide that guides you in a very basic way of, okay, how will you communicate your plan? And now you as a facilitator would talk through this with the individual. So you can see that this intervention doesn't have necessarily a script. Instead, we intended to kind of give you a guide, but everything should be based around centering the participant, validating what they're sharing, and also helping to provide the resources and wisdom that you have as a facilitator to brainstorm ideas too. So maybe the individual is having trouble because they see a different doctor every appointment. That's actually really common in high-risk pregnancy clinics, which are teams which are disproportionately what disabled pregnant people see as their doctor. So that's a challenge, right? Like, how are you going to communicate your plan to this person, and in 4 weeks, it's a totally different person? So sometimes we brainstorm things like, could we send this through your MyChart so that it's uploaded, and specifically ask it to be uploaded as part of your record? And also that those have been opportunities for us to make sure that individual has a printed part of their plan so that they can visually show it to their doctor too. And also it's helpful, I think, to bring that up, to say, gosh, as I'm getting closer to birth, I know that the clinic's way of doing things is I see a different person every time, but I'm wondering how close will we be to scheduling who I will actually be working with on the day, if we'll know, and how can I get this plan across? So we practice things like that and actually help people to know what to say if they're not sure. Next slide. So we talk about, how our team, when this slide has a couple of different illustrations on it. One appears to be a pregnant person with a doctor, and one appears to be, two people chatting. One person looks to be her hand on her belly. So I preface this one a little bit in terms of, we look at lists of what has helped others, and remembering that formal and informal supports are meaningful. So sometimes I think that we get stuck thinking about accommodations only as, what type of official support can I get from medical equipment or from a person who has a certain degree or certification, and that informal supports are extremely helpful as well. So informal supports might look like, calming phrases that help a person kind of remember to take a deep breath. Informal supports can look like things they bring from home that have helped them, that might not be medical or in any way, but that may help them with positioning or to be comfortable. Informal supports can be signs to let people know before they enter a room what a person's preferences are related. I know we've worked with individuals who have had a sign out front related to masking their preferences. So remember, those informal supports are great as well, and helping people to think about what's been helpful in the past. And then if you get to a barrier where a support is missing, that may be that opportunity for you to research as a facilitator between sessions. Next slide. Thank you. All right, so this is another peek kind of into what the intervention itself looks like, where we have a discussion in the third session about how a person will take care of themselves during labor and birth. So sometimes this can open different discussions related to, sometimes related to medical trauma, where people have felt like they haven't been listened to or they haven't been heard. So we talk about how can we make sure that a person has an opportunity to hopefully not re-experience trauma in this setting. And so things like, who do you want with you if possible? Who do you not want with you if possible? You know, sometimes lighting, if changes are possible with that, can be really important to a person. So just again, having this opportunity to think about how will we care for ourselves as the pregnant person. And I think this is also intentional in that very quickly the shift can be towards kind of only thinking about the baby, which of course the baby is very important, but as is the pregnant person, so the mother. So this slide kind of reminds us to talk about that. Next slide. And then we'll talk about what do we need in the hospital. And we think about this in the context of, unfortunately, hospital rooms and the hospital system is quite inaccessible for many people for their disability related needs. So we talk about things like, you know, the hospital food delivery is typically sort of very set times. Will some snacks be helpful in between? How do you know, another thing that we've put in someone's plan is this mother was blind and she was very concerned about how many times when hospital staff come in, they sort of inadvertently move things around like IV poles, tables, and that was going to be really dangerous for her as she was in an environment that she didn't know as well as she knew her home. So she wanted a clear path to the restroom without people putting things in her path. So that was part of our plan and how we would communicate that out. So we think about what you need in the hospital, but again, much more than you might see, you know, in a pregnancy magazine that says, you know, here's what to put in your hospital bag. We also think about it in terms of the interaction between disability and inaccessible hospital environments. Next slide. So words matter. We know that. And this is actually a slide from the intervention. We want to talk to people about the experiences they've had related to stigma, ableism, or discrimination. But I recognized very early in this process that I, as a researcher who studies ableism, that's not necessarily the word that everybody uses to express their experiences related to judgments, misconceptions, discrimination that people face. So we talk about, you know, what words make sense for you, and that's where you lead the rest of the intervention with. So, you know, it's not important that it lines up with research papers. It's more important that it lines up with what makes sense to the individual. So, and I've had all and more of the words that are on this slide. I'd say that probably what's most common is some combination of ableism, discrimination, or judgments. Is are words that people feel. Next slide. And so this is one of the slides that allow us to further that discussion in terms of how can you cope with stigma and how is it connected to what matters most. So this allows us to sort of tie those two things together, and again, empowering people and having autonomy in their plan. Next slide. All right, so finally you get to have a quick look at what a plan looks like. And so again, we have to, for practical purposes of having it on one page, it's quite a bit of text in 3 different columns. So there is the purple column on the left that is plans for pregnancy, and then we have plans for labor and birth in the middle, and then we have supports and plans for after birth. And so this is divided into a couple of different headings. The first heading in each column is the best environment for me. And then it has kind of what is needed. So options like, and this is an example plan, obviously, has the option of an adjustable exam table, includes options for comfortable seating, may include my support person or people, and is flexible with timing. And then the next section is providers can help by, and this person has included in their plan talking directly to me, providing information in advance, providing written summaries, limiting touch, confirming my consent, recognizing and accepting my knowledge about my disability, helping me with transitions if needed, supporting me to manage stressors, and understanding that my pain changes, but it can be significant. And then always we include at the bottom what matters most to me. And so for pregnancy, this individual included doctors who are informed about OI or willing to look into it. And OI was this person's specific disability. So they wanted that listed. And then the plan follows across here. You can see obviously it varies a little bit if I take a peek into the labor and birth. So we have some of the things that carry over, but we also, it's noted that the best environment for me includes access to a bath or shower or a shower with a shower chair. So we've included kind of something disability specific. And then we've got some different notes for providers too. Things like providers can help by asking about my pain with descriptors instead of numbers. So something very specific that they had sort of learned from their past was more helpful. And then last, I'm going to switch to the supports for plans after birth. So the best environment for me recognizes my symptoms are changing and dynamic and accepts our decisions about breastfeeding. So this individual actually didn't yet know how she was going to decide about breastfeeding, but she wanted her decision to be accepted and respected once she made it. And so that was included in the plan. And then providers can help by, and this again is after birth, recognizing and accepting my knowledge about disability, screening for postpartum mental health concerns, and communicating a clear plan about recovery from birth, when to resume medications. This gives you kind of an idea of what the plan looks like. Next slide. And this slide has a demographic overview of some of our participants in the pilot program. So you can see that we had a fairly wide range of different disabilities included, and I'll read some for accessibility purposes. So we had participants who were blind, participants who had spina bifida, Ehlers-Danlos syndrome, psychiatric disabilities, COVID, Graves' disease, long COVID, POTS, permanent connective tissue disorders, rheumatoid arthritis, and osteogenesis imperfecta. All right, so now we're going to have a chance to jump into kind of your opportunity to put to use what you've learned so far. So I want you to imagine yourself in the role of a facilitator, and you are working with an individual who you've had a chance to chat a little bit about their pregnancies, built some rapport. And so now you're to one of the final slides in session one, where you're going to help this person zone in on what matters most to them. And so one of the things that they are challenged by and stuck on right now is that they would really like to pursue a birth where their partner could be present, but they're being told that that's not possible, and that they need to have a cesarean section. They're not sure why. They just feel like they were told that very early on and didn't get much information. But for them, they're not sure what matters most yet. But they're talking about how they worry that they'll be alone. They'll miss the opportunity to hear their baby's first cries. So I want you to take an opportunity in the chat to kind of think about what you might say to this individual to help them zoom in on what matters most. And so I'll say on right now, there's no right or wrong answers for this. It's just giving you an idea of that. One of the both challenges and I think magic pieces of this is that rarely have any participants said to me, "Oh, I know exactly what matters most, and I can say it in one sentence." Usually they sort of put forth their story, and you talk through it and help them kind of put it into a sentence. And so where might you go with this? And it can look different for everybody. So if you'll drop it into the chat, we'll look through those for a bit together. Yeah, restate the question. So I'm wondering, if you were the facilitator and you had an individual who came to you and said that she'd been told that she had to have a C-section, she wasn't sure why, but that actually wasn't what she wanted. And one of the reasons that she was concerned about that is because her partner wouldn't be able to be with her. So how might you go about helping her hone in on what matters most? Great. So questions are a super effective and validating way to find out more information. So Bonnie suggests the question of, is there one particular um, part of this you're particularly concerned about? So one particular thing that you're particularly concerned about. So trying to get more specific. Um, Lisa is suggesting, so you would suggest to the individual participating, what if we contacted your doctor to ask for clarification on why you need a C-section? And so you could even help the person either, if they weren't sure how to ask that question, you could even help draft it out for a my chart, or for them to call and know exactly what to say. So as a facilitator, you yourself wouldn't call the doctor, but you would empower the person to call their doctor. Exactly. Yeah. Zaya, and I hope I'm pronouncing your name correctly, has suggested, would you like help informing some questions for your providers to find out why they're recommending a surgical birth? Um, yeah, I've heard many providers say that the important thing is that everyone survives, but I would want more than that. Yeah, I would need a little bit more information. Um, yeah, looking at more complete, uh, getting more complete conversations with providers. And then Alexia says, as a doula, I never worded it as what matters most, but I would probably use this in my birth plan discussion. So maybe to mom and dad, what matters most to you about your birth and postpartum experience. Zia, thank you, Zia. I appreciate that. Exactly, Erica. So reflecting back the values that you hear and brainstorming about what questions you might ask to get more information. And remembering too that when you wrap up that first session, you don't have to have it perfectly worded. You are going to have an opportunity to, especially with wordsmithing, certainly don't worry about that. You'll have an opportunity to get that right. And people's plans should be reflective of their wording as well. Again, it shouldn't be written in research speak or in anything that isn't accessible to the individual. And then finally, Catherine is adding utilizing clarifying questions and reflections to elicit how they would like to move forward and work together with her medical team to advocate for best outcomes for patient and baby. Absolutely. Yeah, and I really like this suggestion as well, Jillian, exploring what might help them feel safe if they do end up needing a C-section. So, our role is not to make decisions or suggest things in a provider role in any way. We just are sort of this hopefully empowering partner uh, to the patient or disabled pregnant person to feel like that their needs and wants and values are heard and validated, and then helping to communicate those, because we know that there are so many barriers that exist in healthcare systems. Exactly. Yeah. Thank you for bringing that up, Danielle. It can change. And even if we write it in the plan, and many times people will say, can you go ahead and send that plan to me? And I say, yep, I'll send it to you today. Remember, we might change it at the end. Yeah, so the most dynamic plans change quite a bit. And that was just the last point I was going to make on that. So next slide. I think this next slide is the recruitment flyer that we use to give you an example of kind of how you might explain this process to people. Of course, we were piloting, but there is a need, I think, to explain to people who this may be helpful to what you're doing. So we wanted to share this with some of the key details that let people know if this might be helpful to them.
Kara,
Yeah.
can I ask, are you still looking for participants for the pilot?
Yeah, we would be happy to take some additional participants. We, for this part, have wrapped up the initial, but I think additional participants would help us learn how to make it even better. And we've got some great suggestions today in the chat too about diversifying some of our illustrations and images. I caught that. Yeah, if people would like to participate, we would love to have them.
Fantastic.
All right. And I caught one more. And I'm sorry, I might have missed somebody.
We have some questions in the Q&A.
Let's take that.
Okay, so the first one is, if a pregnant person with a disability does not have any disabled peers to help create an APAP, what should they do?
Great question. So our hope is that we would sort of have a growing little army of facilitators out there. So we've thought of places like Centers for Independent Living might be a great place to train people. Ideally, you probably wouldn't, as a pregnant person, kind of go find I mean, I guess you could, but we're hoping that we'll empower and equip enough facilitators that they will reach out and offer kind of this, or we're hoping that also people who are sort of already doing birth planning work, maybe doulas or midwives, or it'd be great if OBs would add something like that if they were disabled. So I think in most cases the facilitator would be in place and then try to reach out. But so that's an interesting um, other approach too.
Someone in the chat is asking, can these slides be shared or the flyers for the study be shared? We can share these slides in our wrap-up email that will go out with the recording, and also we will direct you with a link to the actual facilitator's guide. I put it in the chat. We have another question here which says, I am a doula and wonder how I can connect with a peer support person or incorporate this planning in my care. I am also disabled, FYI.
Oh, great. So you could be a facilitator. So we hope that today would give you kind of the first steps of that. And then having the facilitator guide would give you some more details and fill in. We have some things in there that are kind of commonly, maybe and we have a little bit more scripting in there too, in terms of you could say this or you could say that. So I hope between the facilitator's guide, today's webinar, there's also a short video on our facilitator website. And then I'm always happy to meet with people. If you just shoot me an email, I'd be happy to set up a Zoom to make sure you feel as prepared as you can be for that first session.
And Kara's contact information will be on the slide at the end of this presentation and is also on the link for the website for the APAP that we'll be sending out. Can we get the next slide? One of the key things we do at the Lurie Institute is platform and amplify the stories of disabled people. And for our disability and pregnancy work, that means amplifying the stories of pregnant disabled people and disabled parents. If you are a disabled pregnant person, you've experienced pregnancy, if you are a parent with a disability, we would love to hear your story and to promote it on our blog. We produce blog entries on a rolling basis, and we offer a small honorarium for contributing to our blog. So you'll see the QR code right there at the bottom of the screen. And if you have a story to share, either in English or Spanish, we would love to hear it. And with that, I want to thank you so much, everyone, for attending our webinar today. You'll see in the chat, Amy is putting a link to a survey. We would love to hear your feedback about this webinar. We appreciate your patience with our technical issues. And if we could just very quickly go back 2 slides to the lactation webinar. Or the lactation resource, I just want to amplify this as well. We produce this in-house with the assistance of an IBCLC who has a physical disability. And this is a web-based resource on breastfeeding and nursing and pumping for disabled parents. Please feel free to keep in touch with us on social media. We are on all the platforms, including Facebook, Instagram, LinkedIn, TikTok, and Blue Sky. Our communications team is making sure that we are everywhere. Thank you again so much for joining us. Thank you to our interpreters and Dr. Kara Ayers, and we hope you have a wonderful day and a wonderful rest of your weekend.